Welcome to the official podcast of the Cardiology Advanced Practice Provider Conference. Today, we are exploring one of the most dynamic and high-stakes areas in the cardiovascular critical care, mechanical circulatory support in heart failure.
So from temporary devices like Impella and ECMO to durable LVADs that are implanted surgically, mechanical support has redefined how we stabilize and sustain patients with advanced heart failure and cardiogenic shock. But with these advances comes some critical questions. More importantly, when do we initiate support? How do we manage complications? And how do we integrate a multidisciplinary team of advanced practice providers to get the best outcomes?
We're excited to discuss all of that and more in today's conversation. Before we dive in, let's take a moment to introduce ourselves.
Hi, everyone. My name is Derek Pineda. I am a nurse practitioner in the cardiac cath lab at Mount Sinai Hospital in New York. And my current role as an advanced practice provider in the cath lab is to scrub and support cardiac cath procedures. And I've been doing this for almost 20 years.
My name is Sonia Chahal. I'm a physician associate here at the Cardiac Cath Lab in UCSF. I also work in cath lab and interventional APP. My role is very similar to Derek, but I do not have 20 years of experience.
So together we'll be sharing our perspectives and our experiences managing mechanical circulatory support in critical care settings, particularly looking at patient selection. When do we escalate? And what are the things that we consider for patients post-support recovery? And how do we support their long-term outcomes?
Whether you're already a part of a heart failure program or looking to expand your role in advanced cardiac care, we hope this episode provides insights you can apply directly in your practice. Let's get started. So to start off, Derek, can you walk us through the current landscape of mechanical circulatory support and where these therapies fit within the spectrum of heart failure management?
I think that's a great place to start, Sonia. So looking at the landscape of mechanical circulatory support, obviously before these technologies were around, we relied on inotropes and medications to support patients' blood pressures when they were in shock. Probably in the early 90s or maybe even before that, we started with the balloon pump era, the intra-aortic balloon pump for counterpulsation. And then after that, we got into some more mechanical circulatory support devices like LVADs, Impella, and now we're using ECMO as part of the landscape and the tools that we have to support these type of patients. Sonia, when you're thinking about these devices, what are some key clinical indicators or red flags that help you determine when a patient may need escalation to temporary mechanical support?
I think that can view in a different ways. Like if you are already managing a patient in heart failure service, then as you're closely following up and see that if patient having frequent exacerbations and came to the or transfer from anywhere from other hospital in a cardiogenic shock, or even as an inpatient, if sometime post-CT surgery patients or even advanced heart failure patients admitted for some other reasons of the decompensating and they need immediate escalation in terms of showing symptoms of hypertension, lactic acidosis and organ failure of failure, including renal failure, liver failure, and more because of due to poor perfusion. So that's where we kind of come in and call active, code MCS and have mechanical support available for the patients.
Yeah, I think those are great places to look at. I know that Sky has basically classified the shock stages, which is the Sky shock stages, which is graded from A to E, A being at risk and E and basically extreme where they're in cardiopulmonary collapse, CPR, severe acidosis. And these are patients that need maximal support. A lot of times we guide our therapy also based on what the lactate levels are. So there's this idea now that we should be doing door to lactate patients. Door to lactate, very similar to like door to balloon in STEMI patients. When we see hypoperfusion, even before blood pressure drops, and hopefully the goal, and which is being supported now in more contemporary trials like danger shock is that we can actually escalate these patients a little bit earlier than we typically would, with the goal of lowering their mortality, which was seen in these trials. Um, Sonia, there's several device options that we talked about: Impella, ECMO, LVAD, several others. How do you approach device selection based on patient presentation and hemodynamic profile?
Um, I think it depends on the patient presentation and also if it's LV failure or BIV failure. Like, for LV failure, you use Impella or balloon pump, or BIV failure, you use ECMO. And also it depends if in LV size and if patients in again, like how you said that you sort of have stages with a cardiogenic shock. If the patient's ischemic and you cannot put on any more inotropes or anything, and they're having frequent arrhythmias, you have to consider balloon pump. If Also considering if RV is strong enough to tolerate Impella or LVAD. Um, Other things are like if in terms of you know presentations, again, I said the size, the bigger the device and higher the risk is. So if you already have patients crashing or coding, you can use ECMO and for acute debilitating um, situations. But if there's a slow decline, and you can have more better planning. And also in terms of sometime you wanted to see if it's a bridge therapy you wanted to use, or if you want to use a destination therapy. Um, a lot of socioeconomic conditions, a lot of support, all that it's as well as consider. Um, what else I was going to say? Um, and also, if patients who are not surgically candidate, then you have to consider, you have to plan in a way that is this going to be a destination therapy versus are you going to bridge them?
So I think you brought up some really great points. I know obviously the degree of therapy would really depend upon the stage of shock that they're in. Obviously, with patients with a lower sky shock stage, we wouldn't be jumping at ECMO. So, like you said, I think the clinical presentation is really important to understand whether or not we should use inotropes or vasopressors, really to understand the hemodynamics before escalation of therapy, because a lot of the times also with Impella and even ECMO, uh, the risk the risk of bleeding with the access for these devices are quite high. And I think you phrase it quite well for LVADs. I mean, looking at what these patients are, their patient profile, whether or not they're candidates for transplant in the future. And like you said, is it a bridge to transplant or therapy? This will be their destination therapy. These LVAD patients we see in really late stage patients that are really waiting for heart transplant, if they're eligible for heart transplant or if they're not for whatever reason that may be.
Absolutely. Yeah, speaking of that, what are the some common pitfalls and complications that providers should be vigilant about when managing patients on temporary MCS, or how do you troubleshoot them in real time?
So whether it's balloon pump or we go all the way to ECMO, I mean, all these devices require some degree of vascular access, and the greater the support, the larger size of that access is. And with these type of vascular access and these particularly large bore access, comes the risk of bleeding. So bleeding is a tremendous risk that's associated with these patients, particularly since you need to also anticoagulate these patients while on these therapies. So that's one of the biggest things that we think about, and um, particularly need to be very vigilant about monitoring these patients, particularly their access site, and whether or not we see any issues. The other thing also is that, you know, using these devices, we are improving the flows, but we also need to understand the patient's hemodynamic status. So, they also need to be euvolemic. If Particularly if we're putting ECMO patients and these are dry patients, that we won't have anything really to be moving around. So it's a little bit difficult of a challenge to manage these patients hemodynamically as well. Sonia, what do you think in your practice?
Yeah, I agree with you. Like, hemolysis or GI bleed, patients with any other like organ issues. Stroke is one of them, but again, the bleeding is always the major one. And also infection, the access and site. It's those are the I was I remember I was in bleeding, we're talking about like why patients coming with infection, because also sometimes patient has a um taking some immune suppression for some other reasons, and or lupus or anything like that, so they have to be considerate. And that can increases increase their complications.
Also, I think another thing that needs to be looked out for is the risk of AKI with mechanical circulatory support, particularly with cardiogenic shock. So, when we're monitoring these patients, these are all the things that we're thinking about, and what we need to do to support these patients to them to make a recovery, and with the goal of having some reasonable or meaningful long-term recovery. I know we talked about the multidisciplinary approach, and considering the patient support and a lot of other things besides what we see when we look at this patient laying in a bed. But from your perspective, what do you see as the most critical skills or competencies needed to effectively manage these patients receiving MCS in the ICU?
You know, the critical skills there, basically, you have to know your patient. I think our APPs and even the nurse coordinator, they are trained well. They have to be really have hands-on training as well. They have to work with the vendor specific, systems. You have to like understand each piece of equipment, how they work, what the complications, just like we were talking about side complications or stroke or like all that. Um, the joint commission, there's a joint commission certifications for LVAD. I believe that that's also for other MCS devices as well. And you have to sort of have well aligned with perfusionists as well. Um, we have nurses that go to OR during the procedure time, when they ramp and adjust the LVADs right there, and they provide a full inpatient care, patient education, caregiver education, all the discharge, and also have to connect with the community, skilled nursing facility. There's just there's a lot of like training, like not just the critical skills, but just that the overall. There's a huge spectrum of training that APPs or MC or any MCS coordinator that kind of have to practice that. Um, and that, you sometimes you work with different companies and you get Abbott training and Medtronic training, Heart Lab training. They're all different kind of credential they also have to keep up with. Speaking of that, I want to go over more into that. How do you approach weaning and transitioning rather to recovery, durable support or transplant, and what factors influence those decisions?
I think that's a really great point. I know that we've always stressed about the idea of escalation, but we really need to understand also is, even before we put these patients on MCS, we're already begin assessing their readiness to wean or what their recovery is. For patients that basically have terminal disease or, um, you know, really end stage organ issues, we were very hesitant to consider using these devices. But for particularly younger patients that were healthy and walking in, and we see this a lot also when we assess these patients rapidly during ECPR. We're always assessing their readiness and need. But when we look at these patients, we're looking at some clinical indicators of recoverability. Basically, are they maintaining their blood pressure with minimal pressors and obviously with lower levels of support? We look at their hemodynamics. Um, we're looking at their index, their wedge pressures, and trying to see if there's any meaningful improvement in those numbers. Some of the other markers that we're looking at is some metabolic markers. Is lactate improved? Are they making urine? Are their extremities warm and perfusing? If there's any AKI or any kidney injury, is the creatinine downtrending? Any improvement of the liver function? lab values, and also what's their neurological status. Sonia, I know this is before you came to the cath lab. I know that you were echo tech, and when we look at the heart, do we see that is the LV unloading effectively, has contractility improved, particularly in patients in cardiogenic shock and they have a MI, a profound MI, and we ended up putting an MCS device. We're looking to see that the issues that put them in shock to begin with has improved. Um, for device specific things, we obviously want to see if we can decrease their decrease their levels of support while still maintaining stable hemodynamics. And for ECMO, also we're looking for improved pulsatility, showing that the native heart is really starting to take over. And we're able to see that in the atrial line waveform. But before we do all these things, and once we think that these patients are ready to wean, then you really take these stepwise attempts at reducing their support to see how these patients do. With the Impella device, we are able to lower the level of support from like P8 to P6 down to P4, while at the same time we're all monitoring their pressures, MAP, also lactate, and also with this lower level of support, we'll also repeat an echo just to see how the ventricle is functioning with lower levels of support if the native heart is able to take over. With ECMO, it's a little bit more complex because that this is full cardiopulmonary replacement. So the key is to really gradually reduce the ECMO flows down to 1.5 to 2 liters per minute, and really watch on what the map is, particularly if we can do it without increasing the vasopressor doses, the restoration of pulsatility, again, LV function on echo, the RV able to handle this increased preload, and again, the metabolic functions, is the lactate stable and are the lungs improving? So before we even do these things or implant these devices, we really do a multidisciplinary assessment to these patients if they have the support. One, if they can support these type of therapies, and two, that even if we take them off these mechanical support devices, they still have a long road ahead of them. So these are all factors that we all take into consider before placing these devices. Sonia, what are your thoughts regarding that?
Yeah, I agree with you. For the ECMO, you have to see that if they can really decannulate or can't even bridge to Impella or anything. But absolutely, you touched all the right points, and the importance of a multidisciplinary team involvement to address everything in from how they're weaning, the medical, clinical improvement, as well as psychosocial support, to see which direction actually they're going, if they're able to wean off, or if they are going to be, listed as for heart transplant. But there's a lot of, it's a huge, thorough evaluation that they have to go through to make sure there's nothing contradicting them otherwise, if they have to go through a heart transplant. It's interesting that now our institution is doing like independent patient, even RAD or heart transplant initiative, where if you do not have a full like social support, but you are independently able to take care of yourself, that you're able to own your, take the ownership in terms of even managing your devices, that you can actually get a candidate for that. But it's a very thorough process as well. Just to kind of understand that we are able to offer the best care to our patients. Looking ahead, what emerging technologies are or innovations in the mechanical circulatory support excite you most, and how do you see them changing the way we care for advanced heart failure patients?
So one of the things that I know even our center has participated in these are these newer MCS devices, or particularly the percutaneous LVAD space. One of the things that we know are coming, and we're really just waiting for regulatory approval for these devices, are really smaller French devices that allow us to really reduce the vascular risk, since we're able to implant these devices percutaneously, get relatively the same amount of support while effectively making a much smaller hole. And I think that um, that will really pave the way for more opportunities and more patients that would be eligible for these type of therapies. Um, these are all, there's so many things that we consider before putting an LVAD, um, or any MCS device, whether it's Impella, or even ECMO. And, we are, before we place these devices, we always do this calculated risk about whether or not there always will be a benefit for these therapies versus the risks involved. So I think one of the things that I'm particularly excited for is, just like I said, is seeing these smaller French devices, which I think will really change the way that we look at escalation for mechanical circulatory support, just because we know in the interventional space, these smaller French, 9 French type systems will obviously reduce the risk and potentially open the doors for more patients.
Yeah, absolutely. I think I can heard about that as well. That even up to 8 or 9 French, like smaller size Impella sets, they're making that, and also total artificial heart that where, like, especially in the IV failure, where patients not transplant candidate, and then hopefully more of that can help patients, and as emerging technologies, and we can have a better technology to sort of have that offer this to people that completely has no other hope.
So this pretty much wraps up our discussion on mechanical or circulatory support in heart failure critical care. We really hope that today's conversation gives you some practical insights and new perspectives on caring for some of our most complex patients.
Yeah, we also want to make a moment to say how incredible this year's CAPP conference was, and inspiring few days filled with education, collaboration, and connection among colleagues who are driving the future of cardiovascular care.
If you joined us this year, thank you so much for making it a success. And we couldn't do it without you. And we couldn't do it without all the speakers and such great content. And if you couldn't make it, we hope to see you next year at another outstanding CAPP conference experience.
Well, until then, thank you for tuning in, for all you do for your patients, and for being part of this growing community of advanced practice providers transforming cardiac care. Take care, and we'll see you next time.